Take a small piece of ice. Place it on your tongue. Do not chew it yet. Just hold it there. Feel where the cold goes first. Notice the small, involuntary clench at the back of your jaw. Notice the half-second widening of your eyes. Notice the way your breath catches without you asking it to. Something is happening inside your head that you did not authorize. A signal has already left your tongue. It is climbing a nerve that runs straight into your brainstem. I want to tell you what that signal is doing. The nerve carrying the signal is called the trigeminal nerve, the fifth cranial nerve. It is the largest of the 12 nerves that emerge directly from the brain rather than the spinal cord, and it lives buried in the bone behind your face. If you press a finger to the side of your nose where the cheekbone begins, you are pressing against territory the trigeminal nerve serves. If you press above your eyebrow, same nerve. If you bite down and feel the pressure on a tooth, same nerve. If you feel the cold of the ice you just placed on your tongue, same nerve. The trigeminal nerve splits into 3 branches inside the skull. The ophthalmic branch runs to the forehead and the eye. The maxillary branch runs to the cheek and the upper teeth. The mandibular branch runs to the jaw, the lower teeth, the front of the tongue. That 3rd branch is the one carrying the cold signal you produced when you placed the ice in your mouth. These 3 branches meet at a junction called the trigeminal ganglion. It sits in a small depression in the bone near the temple. From the ganglion, a single trunk plunges into the brainstem. It arrives at a structure called the spinal trigeminal nucleus. From there, the signal does not travel up to the parts of the brain that think in words. It travels to a much older part of the brain, the part that decides whether you are awake, whether you are alarmed, whether you are about to die in the next 4 seconds. That older part of the brain includes a tiny cluster of cells the size of a grain of rice. It sits on either side of the brainstem, just below where the pons meets the midbrain. Each cluster is called the locus coeruleus, which means the blue place. It is called this because under a microscope, the cells appear pigmented blue from a copper-containing molecule called neuromelanin. There are about 30,000 cells in each locus coeruleus, 60,000 cells in total, in 2 structures together no larger than a grain of rice. And these 60,000 cells produce nearly all the noradrenaline in your brain. The locus coeruleus is the brain's alarm bell. It is the structure that wakes you at 3 in the morning when something is wrong in the house. It is what fires when you nearly step in front of a car and feel the surge of clarity that follows. It is what allows a sleep-deprived parent to be sharp during a child's emergency. The locus coeruleus does not deal in subtle modulations. It is mostly off, or mostly on, and when it is on, it floods the cortex with noradrenaline through a vast branching network of axons that reach almost every region of the brain. Now you may be wondering why I am telling you all this when I asked you only to put a piece of ice on your tongue. The reason is that the trigeminal nerve, when it carries a strong cold signal, has a direct line to the locus coeruleus. The nerve does not just register cold. The nerve fires the alarm bell. There is one more piece of architecture you need to know about, because the trigeminal cold signal does not stop at the locus coeruleus. It also passes through the nucleus of the solitary tract, which sits a few millimeters away in the medulla. The nucleus of the solitary tract is connected to the vagus nerve, which controls your heart. So a single piece of ice on the tongue, through one nerve, triggers 2 simultaneous responses in 2 different brainstem nuclei. One of them releases noradrenaline, the other slows the heart. That is the architecture. Now I want to walk you through what each of those signals is actually doing. Let us go back to the moment the ice touches your tongue. There is a specific molecular event happening at the surface of the nerve ending. Sitting in the membrane of the trigeminal nerve fibers in your tongue is a protein called TRPM8. It belongs to a family of proteins called transient receptor potential channels. Each one is a tunnel through the cell membrane. Each one is normally closed. Each one opens in response to a specific physical stimulus. TRPM8 is the cold channel. It opens when the temperature around the nerve fiber drops below about 26 degrees Celsius, which is roughly 79 degrees Fahrenheit. This is well above freezing. You do not need ice to open TRPM8. Cool water will do it. But ice opens it harder, opens it longer, opens it in a more concentrated way at the precise nerve endings the ice contacts. When TRPM8 opens, it lets calcium and sodium ions flow into the nerve fiber. The flow changes the electrical charge across the membrane, and once that change crosses a threshold, the nerve fires. David Julius, a physiologist at the University of California, San Francisco, won the Nobel Prize in Physiology or Medicine in 2021 for the discovery of these channels. Julius and his colleagues demonstrated that TRPM8 is the receptor that turns the physical event of low temperature into the chemical event of nerve signaling. He also showed that the same channel is activated by menthol, which is why peppermint feels cold even though peppermint is not actually cold. The molecular machinery does not know the difference. The channel opens, the nerve fires, the brain receives a cold signal, and the brain reacts to that cold signal whether the temperature is actually low or not. I want to point out something curious here. The trigeminal nerve carries a higher density of TRPM8 channels than almost any other nerve in the body. More than the skin of your arms, more than the skin of your face. The most cold-sensitive territory you have is inside your mouth. And the most cold-sensitive part of the inside of your mouth is the front of the tongue. So when you place a piece of ice on the tongue, you are activating a higher concentration of cold receptors than you could activate by putting your face in a bowl of ice water. Your tongue is, in a way that we do not usually appreciate, the cold-sensing organ of the body. The signal that fires from those TRPM8 channels travels along two different fiber types. The fast fibers are myelinated A-delta fibers. They travel at about 30 meters per second, which means a signal from your tongue reaches the brainstem in well under 1/10 of a second. The slow fibers are unmyelinated C fibers. They travel at about 1 to 2 meters per second. They carry the lingering, dull, aching cold that you feel after the ice is melted. Both fiber types arrive at the brainstem. Both contribute to what happens next. But the trigeminal nerve does not only inform, it also orders. Once that cold signal reaches the brainstem, it does something to your heart, it does something to your blood vessels, it does something to your blood pressure. And all of these things are coordinated by a reflex that has nothing to do with you putting ice in your mouth and everything to do with what happens when a mammal's face hits cold water. The reflex is called the mammalian dive reflex. Sometimes the mammalian diving response. Sometimes the trigeminal cardiac reflex. It was identified in seals and dolphins long before we understood it operates in humans. And it operates in humans because humans are mammals. And mammals share an ancient circuitry that turns on whenever the face becomes cold and breathing stops. You do not need to be in water for this reflex to fire. You do not need to hold your breath. You only need to deliver a strong cold signal to the trigeminal nerve. The piece of ice on your tongue is sufficient. Here is what happens. When the trigeminal cold signal arrives at the nucleus of the solitary tract, it activates the parasympathetic nervous system. A signal travels down the vagus nerve to the heart, and the heart slows. This is called bradycardia. In a trained freediver, the heart rate can drop by as much as 50% in seconds. In an ordinary person doing nothing more than putting cold water on the face, the drop is smaller, but consistently measurable. Erika Chagatai, a physiologist at Mid-Sweden University, who has spent her career studying the dive reflex in human freedivers, has demonstrated that face immersion in cold water alone produces an average heart rate reduction of about 20 to 30% in untrained subjects. She has also shown that the response can be triggered by trigeminal cold stimulation without water at all. At the same time the heart is slowing, the small arteries in the skin and the limbs constrict. This is called peripheral vasoconstriction. The blood that would have flowed to your hands, your feet, your face, is shunted toward the core of the body. The brain and the heart receive more blood. The extremities receive less. Chagatai and others have measured this redistribution. The cerebral blood flow can rise by as much as 10 to 15% in some subjects during a strong dive response, even though the heart is pumping fewer times per minute. The body has reorganized its priorities. It has decided the brain matters more than the fingers. Think about what this means. You put a piece of ice on your tongue. 2 seconds later, your heart slows. Your peripheral vessels close. Your cerebral arteries dilate. More blood per minute flows through your brain than was flowing through it before the ice touched the tongue. Not because you exercised, not because you took a stimulant, because you delivered a cold signal to a single nerve. This is not a small effect. The shift in cerebral blood flow that follows a strong trigeminal cold stimulus is in the same range as what a moderate dose of caffeine produces over the course of an hour. The dive reflex produces it in seconds. The reflex does not require water. It does not require diving. The trigeminal nerve does not know whether your face is in the ocean or whether you are sitting at a kitchen counter with an ice cube in your mouth. The reflex is the same. But the brain is not just receiving more blood. There is something else happening at the same time, in a different brainstem nucleus. And this second event is the one that actually produces the cognitive shift you might feel during the next few seconds. More blood, by itself, does not make you sharper. What you need is not just blood. You need a chemical that wakes up the cortex. And that chemical is being released right now by 60,000 cells the size of a grain of rice. The locus coeruleus, that small blue cluster I described earlier, fires when the trigeminal nerve carries a strong cold signal. Once it fires, it releases noradrenaline, also called norepinephrine, into a vast network of axons that branch throughout the cortex, the thalamus, the hippocampus, the cerebellum. Every region of the brain that does anything sophisticated receives noradrenaline from the locus coeruleus. When the noradrenaline arrives, the cortex shifts state. What does that shift mean? It means the receptive fields of cortical neurons sharpen. Background neuronal activity decreases. Signal-to-noise ratio increases. Attention narrows. Working memory loads more reliably. Reaction times shorten. The brain has not received a new piece of information. It has received a chemical instruction to attend more carefully to whatever information arrives next. How big is the chemical release? Søren Nielsen and his colleagues at the University of Copenhagen, along with related work by the Søberg Group in Denmark, have measured plasma noradrenaline levels in subjects exposed to whole-body cold immersion. They have shown that noradrenaline can rise by about 300% during a few minutes of cold water at 14 degrees Celsius. That is a large effect, but that is whole-body cold. The trigeminal cold signal from a piece of ice on the tongue does not produce that magnitude of plasma noradrenaline release. The systemic effect is much smaller. What it produces instead is a localized brainstem activation. The locus coeruleus fires, and the noradrenaline release is concentrated within the brain rather than circulating in the bloodstream. So you do not need a 30-minute cold plunge to activate this circuitry. You need a strong, repeated, well-localized cold signal at the trigeminal nerve. Ice on the tongue does this. Cold water on the face does this. Chewing ice does this with particular intensity, because the act of chewing also activates mechanoreceptors and proprioceptors in the jaw, and those signals travel up the same trigeminal nerve, layered on top of the cold signal, increasing the total firing rate at the brainstem. This is why the people who chew ice, rather than simply suck on it or sip cold water, often describe a more pronounced effect. The chewing is not incidental. The chewing amplifies the signal. Each crunch produces a brief mechanical pulse on top of the steady cold input. The trigeminal nerve fires harder. The locus coeruleus fires more vigorously. The cortical noradrenaline release is sharper. There is a small complication I want to mention. The noradrenaline release from the locus coeruleus does not last. It is a phasic event. Seconds, not minutes. The cortex returns to its baseline state once the cold signal is gone. So whatever cognitive shift you experience from one piece of ice is brief. Repeated chewing produces repeated phasic surges. This is part of why the people who do this compulsively do it constantly, all day, glass after glass. They are not getting a single drug-like dose that lasts. They are getting a series of small pulses, each one short, each one renewing. Now I want to tell you about a population of patients who have been chewing ice for as long as anyone can remember, and who have been told for decades that the habit was just a strange tic. The people I am talking about have iron-deficiency anemia, and they have a condition called pagophagia, which is the medical term for compulsively chewing ice. What we have learned in the past decade about why they do it is, in my opinion, the most interesting piece of physiology in this entire story. Pagophagia is one of the strongest and oldest folk medical observations in clinical practice. Doctors have known for at least a century that some patients with iron deficiency anemia develop an overwhelming compulsion to chew ice. It is so reliable that the presence of pagophagia is itself a clinical clue. A patient walks into a clinic chewing ice constantly, and a careful physician orders an iron panel before doing anything else. The puzzle that has confused everyone for decades is this. The compulsion goes away within 24 to 48 hours of starting iron supplementation, before the iron has time to rebuild any meaningful amount of red blood cell mass. Before the anemia has corrected, the behavior turns off as soon as iron starts hitting the brain. So whatever the ice was doing for the patient, the iron is now doing in its place. And the iron is doing it through the brain, not through the blood, because the blood level changes have not yet had time to occur. Melissa Hunt and her colleagues at the University of Pennsylvania published work in 2014 in the journal Medical Hypotheses, where they tested cognitive performance in iron-deficient patients with and without ice chewing. They administered a sustained attention task. They measured response time and accuracy. The hypothesis was simple. If pagophagia is just a strange habit, ice should make no difference to cognition. If pagophagia is a compensatory mechanism, ice should improve cognitive performance specifically in iron-deficient subjects who are oxygen-starved at the brain level and have everything to gain from a sudden surge of cerebral blood flow and cortical noradrenaline. The result was striking. Ice chewing brought iron-deficient patients up to the cognitive performance level of healthy controls on the sustained attention task. It did not improve performance in healthy controls. It only improved performance in the patients whose brains were oxygen-starved. The dive reflex pulled blood toward the brain. The locus coeruleus woke the cortex. For the duration of the cold stimulus, the iron-deficient brain performed like a healthy brain. This is what physiologists call a compensatory mechanism. The brain has noticed it is not getting enough oxygen, and it has stumbled through behavior on a way to maximize cerebral blood flow and cortical alertness using nothing but a piece of ice. The patient does not know any of this. The patient just feels foggy when she stops, and clearer when she chews. The body has worked it out without consulting the conscious mind. I want you to sit with the implications of this for a moment. Iron deficiency is most common in women of reproductive age, in children, in people with chronic blood loss, and in older adults whose iron absorption has declined. It is one of the most common nutritional deficiencies in the world. Hundreds of millions of people are walking around with mildly insufficient iron. Many of them have brain fog, fatigue, difficulty concentrating, and they have been told by their doctors that the cause is sleep, or stress, or aging. Some of them, without knowing why, have been chewing ice for years. Their bodies have been compensating for a problem nobody diagnosed. Picture a woman in her early 40s, 2 children. Heavy menstrual cycles, she was told, were normal. A constant low-level fatigue, she was told, was being apparent. The fog she felt at 3 p.m, she was told, was her thyroid, which tested fine, or her sleep, which she had given up on improving. Every afternoon, around the same time the fog arrived, she found herself reaching for the ice tray, crunching ice during conference calls, filling a glass with ice, and only a splash of water. Her dentist warned her about her enamel. Her colleagues teased her. Nobody in 20 years ordered the iron panel. Her body had been treating itself with the only intervention available to it. This is the part that I find quietly striking, not the science itself. The fact that the patient figured it out before the doctor did, Now I have to slow down and be honest with you about how strongly we know each piece of this story. Some of what I have described is rock solid. Some of it is well-established physiology applied to a slightly different context. Some of it is reasonable inference that has not yet been replicated as many times as I would like. Let me put each part on a ladder. Top rung, the molecular biology of the cold receptor. TRPM8 is as well established as anything in modern physiology. David Julius received a Nobel Prize for the work. The channel exists. It opens at low temperature. It opens in response to menthol. It triggers nerve firing. The neuroanatomy of the trigeminal nerve is mapped in detail. The signal pathway from tongue to brainstem is not in doubt. Second rung, the dive reflex. This too is rock solid. It has been measured in seals, in dolphins, in trained freedivers, in untrained adults, in infants, in the elderly. Erica Chagate's lab and others have published hundreds of papers. The bradycardia, the peripheral vasoconstriction, the increase in cerebral blood flow following trigeminal cold stimulation are not in doubt. The magnitude of the response varies between subjects, but the direction of the effect is consistent across every population studied. Third rung, the locus coeruleus response, specifically to brief oral cold stimulation. We know the locus coeruleus fires in response to whole-body cold. We know it fires in response to face immersion. We have inferred, based on the trigeminal pathway and the brainstem connectivity, that oral cold stimulation will recruit the same circuitry. The inference is physiologically reasonable, but the direct measurement of locus coeruleus firing during ice chewing in living humans has not, to my knowledge, been done. We are inferring, reasonably, but inferring. Fourth rung, the cognitive enhancement of ice chewing in iron-deficient patients. Hunt's work at the University of Pennsylvania is the strongest direct evidence. The effect was real, the methodology was sound, the result was clear. But it is one research group, with samples in the dozens rather than the hundreds, with one cognitive task. Replication in larger samples would strengthen the finding. The result is consistent with everything else we know, but a single well-conducted study, however good, is not the same as a body of literature. Bottom rung, the most speculative claim, whether ice chewing produces meaningful cognitive benefit in people who are not iron deficient. The Hunt study found no measurable benefit in healthy controls. The compensation only appeared in subjects who had something to compensate for. There are anecdotal reports from healthy adults that cold stimulation sharpens focus, and the dive reflex physiology supports a brief cerebral blood flow surge in anyone. But whether that surge translates to measurable cognitive change in a brain that is not oxygen-starved is, at this point, unproven. So if you came hoping I would tell you that everyone who chews ice will become smarter, I cannot tell you that. The strong claim is for the iron-deficient population. The general physiological response is real. Its cognitive consequences in healthy individuals remain a question. I will not tell you the answer is bigger than it is. The body is interesting enough without me overselling it. Now I want to tell you about a class of drugs that does, on a chemical level, what the locus coeruleus does naturally. Amphetamines, including the brand-name medication Adderall, increase the release of noradrenaline and dopamine in the cortex by acting on the same monoamine transporters and the same vesicular release machinery the brain uses every day. Methylphenidate, sold as Ritalin and Concerta, blocks the reuptake of noradrenaline and dopamine, which keeps the released chemicals in the synapse longer. Modafinil, sold as Provigil, has more complex pharmacology, but one of its primary actions is to increase noradrenergic tone in the prefrontal cortex. All of these drugs are prescribed for attention deficit disorder, for narcolepsy, for cognitive enhancement off-label. All of them work, in part, by raising the noradrenaline signal that the locus coeruleus produces naturally when activated. The annual revenue of the attention deficit drug market in the United States alone is in the tens of billions of dollars. A monthly prescription of a brand-name extended-release amphetamine can cost $200 to $300 without insurance. The drug requires a prescription. It requires a doctor visit. It requires a controlled substance schedule. It requires regular monitoring of blood pressure and heart rate. It carries a risk of dependence, of insomnia, of cardiovascular strain. It requires titration. A piece of ice from your freezer costs nothing. Now I have to be careful with the dose. Because if I tell you that ice chewing and Adderall act on the same chemical system without telling you about the dose difference, I am misleading you. The pharmaceutical version is far more powerful. A therapeutic dose of amphetamine produces a sustained, robust elevation of synaptic noradrenaline and dopamine for hours. The locus coeruleus response to a piece of ice is a brief surge, lasting seconds to minutes, much smaller in magnitude. The pharmaceutical version exists for a reason. It treats clinically significant attention deficit. It allows people to function at jobs and in school where they could not otherwise function. I am not telling you to stop taking your medication and chew ice instead. That would be foolish. I do not want you to do it. What I am telling you is this. The molecular pathway through which Adderall works is the same pathway your locus coeruleus uses every time the trigeminal nerve carries a strong cold signal. The pharmaceutical industry has built a multibillion-dollar market on a chemical cascade your brainstem performs for free, on demand, in response to a piece of ice. The natural version is milder. It is also free. It is also available to anyone with a freezer. For the iron-deficient population, the natural version, used at the right moment, has been shown to produce cognitive improvement comparable to a healthy person's baseline performance. That is not a small claim. There is one more comparison worth making. No supplement does this. There is no pill, no capsule, no powder, no tincture you can buy that produces a phasic locus coeruleus surge through trigeminal cold activation. The herbs, the adaptogens, the cognitive enhancement stacks, the nootropics, none of them work through this mechanism. The mechanism requires a physical cold signal at a specific nerve. It cannot be substituted by a swallowed compound. The pharmaceutical can come close because it acts directly on the synapse. The supplement industry, in this particular case, has nothing to sell you that the freezer in your kitchen does not already provide. Let me decode something an older relative may have told you when you were young. If you grew up in a home where someone said to splash cold water on your face when you were drowsy in the morning, that person did not know about TRPM8. She did not know about the locus coeruleus. She did not know about the mammalian dive reflex or noradrenaline release from 60,000 cells the size of a grain of rice. She did not know any of the words I have used in the past half hour. But she had observed, over a lifetime, that a face full of cold water makes a foggy person sharper, and she handed you a recipe that uses a single nerve to wake the entire cortex. She had it right. The science caught up with her 60 years later. If your father told you a cold shower would clear your head, he was triggering whole-body trigeminal and dermal cold receptors, recruiting the locus coeruleus, raising plasma noradrenaline by hundreds of %. He did not know the mechanism. He knew the effect. If a coach told you to stick your face in a bucket of ice water before a difficult match, he was teaching you to deliberately fire the dive reflex moments before you needed maximal cerebral blood flow and cortical alertness. He had no neuroscience training. He had observed what happens to athletes who do it. These were people with no scientific vocabulary who had lived inside their own bodies long enough to learn how to use them. The piece of ice on your tongue is a smaller, more local version of the cold splash on the face. The mechanism is identical. Only the dose is different. Now go pick up that piece of ice again. This time, chew it. If you reach for ice without knowing why, tell me what time of day it tends to happen.